Uh, Good afternoon, everybody. It's our pleasure here to host a new webinar by the Department of South Carolina University Cardiology Department. And we have a very important guest here from the Cardiovascular Center of Sarasota, Professor Mahfouz Shahawi. And Professor Mahfouz Shahawi, he is the president of the International Society of Cardiovascular Disease Prevention, and also he's the president of the Cardiovascular Center of Sarasota in Florida. And we would like to congratulate him because he recently had received the Lifetime Achievement Award citation from the city of Sarasota for contributing to the practice of medicine. Congratulations, dear professor.
Thank you very much.
We have here a big panel of discussants, Professor Mahfouz Shahawi, Professor Jamila Nasser, the head of department at South Carolina University, and Professor Fathi Maqladi, the professor of cardiology at South Carolina University. And we will have very hot topics about the fasting Ramadan. كل سنة وانتم طيبين. Dr. Jamila will start by an introduction, and then
yes, I'm very happy to host this webinar. This is, I think, a very elegant webinar, and I'm very happy to have our guest speaker today, Professor Mahfouz Shahawi. Professor Mahfouz Shahawi, I have, he is my dear professor, and I owe him a lot because I learned from him a lot, and he's my role model in the field of preventive cardiology. I'm very eager to hear from you, a very important topic, and this is about the fasting in Ramadan. And we know that around 1.8 billion Muslims all over the world having this important month, and this fasting, which lasts for 1 month, there are recommendations for being safe fasting, and what about there are new data about that it may have beneficial effects and protective effect on the cardiovascular system, and this is the really very amazing data. We're happy to hear about that. I'm very happy to host this important webinar, and this is in the cardiology department of South Carolina University, along with the Ismailia complex for national insurance in Ismailia. And of course, I do have the honor to co-chair this important webinar with Professor Shahawi and Professor Fathi Maqladi, our legend in cardiovascular medicine in Suez Canal area. I owe a lot to Dr. Ahmed Farid, the lecturer of cardiology, cardiovascular medicine, Suez Canal University, and our perfect imager in our department, because he does everything. He's the one who is organizing this important webinar, and I owe him, and I thank you. Endless thanks due to Dr. Ahmed Farid. We are also very proud to have our speakers from our department. This is Dr. Omar Saleh and Dr. Mohammed Al-Mirri, our dear amazing lecturers of cardiology in Suez Canal area. We're eager to hear from you, Professor Shahawi, and to know more about fasting and heart disease. I congratulate you, sir. I congratulate you, and I think that you are number one all over the world in the field of prevention, and I'm always proud of you, and I congratulate you for the last recognition years ago. Very honored to be with the president of the International Society of Cardiovascular Disease Prevention, and one of the eminent figures all over the world in the field of prevention.
Thank you very much, Professor Jamila, for your kind word. It's always nice to be with you in meeting and see all my friends. And I would like to tell you first, happy Ramadan to all of you.
Thank you.
Thank you.
And I think that's a very appropriate topic. Now, please convey my regard and wishes to everybody else who I might not be able to see or talk to today. Now, the topics you assigned me here about the benefit of fasting, and I would like to come to the slides here to start with here. The first slide, benefit of fasting of Ramadan. So before I go to that here, can you see that? Yeah. So that is our disclosure, our hostel, and I hope one day all of you will come and visit with us here. Ranked among the top 50 in the country. And now here I would like to start with a few questions first. Fasting improves cardiovascular health, while obesity, which exactly the opposite, is a disease. What is the prevalence of overweight and obesity in the United States and globally? As you know, over 100 million American, every third American is obese, and globally is amazing, the number of 430. Now, adiposity is not only just in the belly, very vascular adiposity around the vessels, around the heart, around the kidney are very more important, and we have very nice data to discuss later on in the topics. Now,
excuse me, Professor Mahfouz, would you please do a full screen of the presentation, please?
Sorry. Okay.
Yeah.
The cardioadiposity is a risk factor, while normal adiposity is associated with less cardiovascular structure and functional abnormality. Of course, that's true. Now, here we go to one question about the benefit, really, about the benefit of the intermittent fasting, as we discussed later, is associated with prevention or improvement in the cardiovascular diseases enhancing risk factor. And all of them, as we will discuss, get improved with the intermittent fasting. Diabetes, hypertension, inflammatory biomarker, lipid profile, all of the above. There's amazing the data coming out these days about the benefit from fasting. How intermittent fasting increase gluconeogenesis? Yes, because finally you switch when you're fasting from using the sugar to using the fat, and that's the way you lose the weight, and that is all the whole benefit coming is true. Intermittent fasting increase the gluconeogenesis. Fasting results in lowering blood pressure due the following many mechanisms. Activation of the parasympathetic nervous system, so the vagus take over, and that of course decrease the blood pressure, while the norepinephrine being excreted in the kidney increased. So this is again mechanism, and we have other mechanisms why fasting get the blood pressure down. Now, the recent study have proven that routine intermittent fasting is a good for your health and your heart, because as we already just said, it already improve all the cardiovascular or prevent enhancing risk factor from diabetes, hypertension, dyslipidemia. So that's very, very interesting. Now, finally, Ramadan coming on the scene after all these years. Now, so the objective, a new understanding of the benefit of fasting and its frequently associated improvement in cardiovascular disease enhancing risk factor, along with we have some data to show that even if the patient is still asymptomatic, we can see still if they were obese and did not fast, structural and functional abnormality, which improve after they have been fasting. So therefore, I'm putting this picture to tell you, avoid food pollution. Don't blame it on the gene. The gene just loads the gun, but the environment, as you might see here, is pulling the trigger. Don't look at the food. Self-control like the dog's watching the cat. So fasting, intermittent fasting, and avoiding too much food is great. So we'll discuss that, several points. We'll discuss some of them. I will go in detail, like first the definition and the type of the intermittent fasting, what, since adiposity is a problem, what type of tissue we're talking about, and what is the link, and the benefit of fasting with emphasis how they work. And finally, we show some data from our center of halftime and conclusion and remark. So fasting, the intermittent fasting, that means you can eat and fast, and that's the most common form, and have various time limit. For example, a time protocol. You can fast for 16 hours and eat an 18 hour. You can fast for a 20 hour and very aggressive eat 4 hours. So that is called intermittent fasting. Alternative day fasting, if other day or every 5 days, you have 2 days fast. Yeah. So what I mean with fasting is these alternative days that define, if you reduce your calorie to 400 to 600 calorie a day, that's considered fasting. So that you don't say it's not eating at all with alternate day. And the time restricted feeding, that's like Ramadan. You have from sunset to sunrise, time restricted feeding, time restricted fasting, which have already new data coming out, very, very good improvement coming with that. So here's in writing, intermittent fasting is a form of time restricted eating, typically 16-hour fasting, 8-hour eating, which has gained popularity in recent years and shows promise as a possible new paradigm in the approach to weight loss and the reduction of inflammation. Intermittent fasting has many, many potential long-term health benefits. Currently, the intermittent fasting diet is gaining popularity and considered to be less restrictive as compared with traditional calorie reduction. You tell the patient go home and lose weight and so forth. That's very restrictive and not very exact. So the intermittent fasting have shown to be very easy and very acceptable with the patient. So it could be 16-hour fast, 8, 18-hour 6, 24. So it depends on the protocol. Another approach, as I said, the alternative day fasting, or 2 days a week fast, 5 days eat, etc. Now, that is the definition of alternative day fasting. We'll talk to already what it is, and I'm not going to waste much time here. Otherwise, we'll not be having time for that. And time restricted feeding, that is similar what is Ramadan, which exactly what you have in Ramadan. Certain time you fast, absolute, everything else off. Now, since we said adiposity is the main culprit here, so we need to spend a few minutes to define the various form of adipose tissue and what they do and what happens if we can get them off through fasting. So the adipose tissue classification on 3 forms here: the white subcutaneous tissue, the brown, the abdominal viscera, and here the one I would like to stress on you because they're the least known and the least really addressed. And in my opinion, and our research we're doing, maybe the most important form of adiposity, which is called the inhomogeneous group, the perivascular adipose tissue, not just only around the vessel, but also around your kidney and the heart, epicardial adiposity, gaining now more popularity, although I have been involved with that and talk about this for the last 10 years. Now, what is the difference? This group, they have different messenger RNA than the abdominal visceral tissue. So the abdominal visceral fat have different messenger RNA, and inhomogeneous fat has, which the kidney and the heart belong to. Maybe that could for the cardiorenal syndrome. There's the fact that they have common pathway here. Now, you just picture speaks more than 1,000 words. The subcutaneous fat, the visceral fat, and the heart, around the heart, the epicardial adiposity. Since they have been working with that and trying to bring it out, my colleague in surgery now who do bypass, now finally they tell me you are correct. The more we look at the patient during open heart surgery, the more we see they're really having fat around the heart more than we was giving attention to. So perivascular or epicardial adipose tissue is a major culprit, and we can talk about that later. So getting that out through fasting, and we have now some data and some drugs which can help, so they will be good. So now what is now the definition of this group, which you talk about, which you were trying to go through fasting? Perivascular adipose tissue. Virtually all blood vessels are surrounded by adipose tissue. The heart and the kidney belong to that group. They are inhomogeneous group of fat, have a different messenger RNA. So perivascular adipose tissue encroach directly on the adventitia without visceral layer, and thus humoral factors secreted, hormones secreted, adipokine secreted, have easy access to the blood vessel wall and can function as paracrine organ and can cause the damage when they are in excess. So the pathophysiologic link, this adipose tissue, which you later on will see when the fasting improve all this. Normally, there is a balance. The adipokines and the adipose tissue are the largest endocrine organ in your body. Many people don't think about that. Like in the past, we thought that's just a place with a storage area. No, that's endocrine organ. Normally, there's a balance between hormone, which is atherogenic, and hormone androgenic, anti-atherogenic. So they have here sort of a balance, and I just listed few of these. And specifically, I put in red because many do not know and don't realize that angiotensinogen is produced by the epicardial fat and the perivascular adipose tissue locally, and that might be contributing to some of the problem. So angiotensinogen also produced by these fatty tissues locally. Now, under normal circumstances, I said, like the renin-angiotensin-aldosterone system, there's a balance. Normal vessel, you have balance between the paracrine function of both constricting and dilating versus atherogenic, anti-atherogenic. But if you have excess, then you are in trouble, as seen in the picture. Now, that's not time to go more about the function, and it is good to say that this fat tissue, the perivascular adipose tissue, are increased in obesity and diabetes. Diabetes, even without fat in the belly, has a lot of fat, as we have some studies around the heart, and that might be the reason you're having all this cardiovascular problem with this adipokine secreted directly in sickering the heart. So here's the excess perivascular epicardial adipose tissue and associated with inflammatory marker, C-reactive protein, homocysteine, etc., and decrease in the good hormone like adiponectin, and that is why we see a problem. And that's why we see the benefit from fasting by decreasing this excess epicardial fat, as we'll discuss later on. So that's just a picture about the epicardial adipose tissue. So the pathophysiology here, we're going from adiposity to comorbidity. So the picture here will later on show much better than, sorry about that, it was the other way around. So here's the picture, like for example, the heart. You have the fat around the heart, produces adipokines, which secreted, which can get increase the presence of the cardiovascular disease enhancing risk factor. And I remember it always by saying the A, B, C. A for hemoglobin A1C, insulin resistance, hyperglycemia. B, blood pressure, hypertension. And I'll use also the B for, second B for the biomarker. Increase the CRP biomarker, increase the other biomarker, homocysteine, etc. C for cholesterol, dyslipidemia. So this is reversible risk factors still. If we pick them up early and treat them, it will prevent it from progressing further and creating the subclinical atherosclerosis due to the endothelial dysfunction. And once you have the subclinical atherosclerosis, it might be still you can do something, but can ultimately progress to cardiovascular disease and event and cardiac arrhythmia and death. So we moved here, the pathophysiology, these adipokines, which have been produced, created the problem because of the obesity. The same thing I will show the next picture, I'll put the belly, the visceral fat in the belly, doing the same thing, okay? So that can ultimately cause the problem. So if we can get rid of this problem here, reduce the fat, lose weight, and so we might have a novel approach to help reversing all the side effects. So the benefit of fasting with emphasis on cardiovascular disease enhancing risk factor. So why is fasting good for your health? We already have this intermittent fasting. Who should really be fasting? And I mean, which group of people do you really expect? Of course, people who want to reduce their weight. That makes sense. People who are already obese. So people who get the benefits. So that's very important. So what are, summarizing all what I'm going to say after that here on this slide, what are the benefits you are going to get from the fasting? You get improvements on your blood sugar, insulin resistance goes down, and goes down, the hemoglobin A1C will improve. Your type diabetes mellitus, you might prevent it from happening. You might change from pre-diabetes to normal. Your blood pressure will improve, as have been shown on various studies, and I will tell you why fasting do that. The biomarker profile will improve, less CRP count, less other biomarker causing problem, and the cholesterol. Also, when you fast, particularly the strict fast like you do in Egypt, you don't smoke. And smoking is a major villain for creating problem to the epicardial fat and fatty tissue, and this might be another mechanism by which smoking causing is problem, and we're doing some study on that. So cigarette smoking is not just only for what you read, but also indirect connection with fatty tissue and epicardial fat. So now, let us, yes. I'm sorry, you hear me?
عايز اتفرج يا باشا، انا مالي الشبراء قافله محمد صلاح فايز. بيقولوا لي كده، قول التمريض انا اقول لها في علاج، في ما فيش، ليه ما فيش، ولا يا دكتور عمو.
I didn't hear what you're not coming across clear.
Yeah, we are hearing you. We are hearing you, Dr. Mahfouz.
We are hearing you, sir. We are hearing
Okay, fine. All
you.
right,
We are
we'll
hearing
continue.
you, sir.
All right, we'll continue to finish up that quickly so that you have enough time to ask a question. And I will note that the slide is too busy, but basically, as far as diabetes, we'll say that fasting make the insulin resistance, less, you're more sensitive, and there's some data to show that even improve the secretion of the insulin from the beta cells. So just in short, fasting, well, by getting the weight down, you see the benefits here. The blood pressure now is very interesting. Too many data here have been shown. There is when you fast, activation of the parasympathetic nervous system, so the brain-derived risk factor, okay, which can activate the vagus nerve, acetylcholine, and that is incredible involved with the fasting and lowering blood pressure. Another mechanism they claim also the beside that activation, the norepinephrine excretion through the kidney, increase excretion of norepinephrine. So you get vagotonic and sympatholytic sort of, okay? And increased sensitivity to natriuretic peptide and insulin. These all act for reducing blood pressure with fasting. I have my own additional thing and research I'm doing now. As I told you earlier, that angiotensinogen being produced locally, and that might be another mechanism by reducing this mechanism contribute to the reduction in the blood pressure through fasting and losing weight. Now, this is the hormone which I told you about, which that cerebrospinal brain-derived neurotropic factor, BDNF, that was being activated by fasting, and vagotonic will be the name of the game after that. So increase the synthesis and release acetylcholine by cholinergic neurons. Now, what about the second B? Was it fasting so far improved the A1C, improved the blood pressure. Now, what about the biomarker? Again, the same thing, and study have done, as I said here, and I'm referring to actually was in Ramadan patients. Somebody did that in patient Ramadan, where they found that before they started the fasting and 1 week before they ending the fasting and 3 weeks later versus people who were eating. And they found it that the CRB and the homocysteine interleukin have improvement by fasting. See here, that's a study where they were talking about. What else? What other biomarker? The adiponectin, which is good, protective, which actually for the adhesion molecules will be prevented from adhering and causing problem. So increase in adiponectin. Adiponectin, as you know, is normally down in obesity, is normally down in diabetic. However, when you get them to fast, all of a sudden the adiponectin, the good adipokines will be on the scene. So that is another very important thing to think about, that's prevent the adhesion molecule and all that. Now, what about leptin? Leptin is bad hormone. It is increased with obesity, okay, and can cause a problem. Fasting will also cause improvement in this hormone, this biomarker. So that is, I think. Now come to the lipid. Why cholesterol get down? Why the data? Because normally when you eat, the glucose is taking already effect. So you're giving you the glucose. But when you fast and you already exhausted your glucose, so you start getting your glycogen back from your liver, and the liver already exhausted too, then they start taking the fat, adipose tissue, the fat from adipose tissue, and the gluconeogenesis, and that is the way you do not have enough fatty left to build your cholesterol, and that's the way that fasting improve your cholesterol profile. So the A, B, C have been improved through fasting. Eating window, time will not allow to go much on that, have to be very good. You have to have a good diet, and of course, carotene and the Mediterranean diet, and all of you have enough in Egypt. I go quickly through some of this slide because I would like to come to also prevention of stroke. All this amazing data, really. Just Ramadan and Prophet Muhammad knew that the benefit many years ago before all of us knew about it now. Now we sort of talk about why fasting is so good, with intermittent fasting, you know. Now, we did some publication, obesity, and amazing the data. I will summarize it just quickly in 1 minute, because that will be, we got obese people and non-obese people, and we checked the calcium score and epicardial fat volume along with cardiovascular risk assessment. And guess what? The obese people who have no excessive epicardial fat have less structural and functional abnormalities on the heart than the one who had excessive epicardial fat. Then we look to people who are not obese, people who lost weight, people who fasted. Have two groups: people who have no excessive epicardial fat, slim, but still excessive epicardial fat, not slim. Those who have excessive epicardial fat, although they are not obese, they still have the same problem like the epicardial fat. So excessive epicardial fat seems to be a major actor here. We presented this data, as you see in many abstracts at national and international forum, some of which I present also in Egypt. And actually, as a matter of fact, in 2017, at the EuroPrevent, we were given the award for that particular studies. We got, and I'm not going to go in detail on that. Here's that EuroPrevent award, achievement award for this type of work we did back then. Now, so now we're not going to waste time on that, because I would like to get to the perspective and actually the therapeutic lifestyle changes. I like to tell my patient, how's therapeutic lifestyle? I tell them, look at it like a ball. North for nutrition. Make sure you have not, if you are not going to stick very much to the fasting and the intermittent fasting, make sure you have the good diet, quality and quantity. Make sure the east for exercise. North nutrition, east exercise. South, avoid stress. Smoking, spirit here in the United States, and I'm sure some in Egypt and Saudi Arabia, I know they do that behind the scene. And then West for weight reduction. So remember the lifestyle changes. And now I would like to add to that slide, plus intermittent and frequent diet, fasting diet. That is the best thing you can do these days in advising the kidney. Appetite is the worst enemy. Self-control is good. Now, home message here. Obesity, of course, we know is the root cause of all this problem. It's reversible. The complications are modifiable, as we talked about it, and we can add it, including the, the fasting, intermittent fasting. That is very important to do that, and you can get rid of the metabolic syndrome. And early detect to protect is very important, and all of us have to do that. Take home message. Excessive production of the atherogenic adipokines and local angiotensin are the pathophysiological link between obesity and cardiovascular disease enhancing risk factor, resulting in the metabolic syndrome and atherosclerosis. Fasting will reduce the development of this risk factor, and if you do early enough, you might prevent that from taking place. That's a very important message to know, that fasting, intermittent fasting can do. Early practice of intermittent fasting and identification and treatment of cardiovascular abnormality associated with cardiovascular disease enhancing risk factor, like we're doing now with our risk scoring system, can now be achieved and really very well advised to prevention. Now, medical management now must shift its emphasis from treatment of advanced disease to early prevention. And I compliment Dr. Gamil and us for her getting much more and being behind the scene and on the scene for prevention.
Thank you.
That's really
Thank you, sir.
remarkable. And you're representing us very well in Egypt and Africa, and North Africa, and I wish you well and thank you for all what you do. Now,
Thank you.
intermittent fasting as a novel pathway for cardiovascular health. Intermittent fast, time to recognize intermittent fasting, time to not only just Ramadan or Muharram or Kullu, intermittent fasting will be better. The more, the better. The more, the better. And the earlier, the better. So I'm not going to go to the intermittent reducing the concentration of inflammatory marker, interleukin-6, homocysteine, CRB, all that have been documented already, have been done. So I will not going to go more than just tell you that intermittent fasting have a lot of this to do. So the benefit, all this risk factor here, what you see, can be either prevented or improved so that you don't, by the intermittent fasting, so you don't get to the stage of type 2 diabetes or cardiovascular disease. The intermittent fasting diet present a useful substitute to obese, overweight patient who find the continuous energy reduction is difficult to maintain. We have to be all preventive healthcare providers, and we have to get the advice that keep in mind TLC, not tender loving care, total lifestyle change, nutrition, intermittent fasting, exercise, cessation of smoking, and weight reduction are paramount importance. Now, consider intermittent fasting as a novel pathway for cardiovascular disease risk reduction, and happy Ramadan. And if you don't do that, you will end up like David returning to Italy after 3 years in the US. Thank you very much. And I will be open to any question you might have.
Thank you very much. And really, we're very honored to have our dear professor, Dr. Fathi Maqlidi, with us and to start the discussion with you, sir.
Dr. Mahfouz, thank you very much for this very wonderful presentation with a lot of new points which was not very clear to us and very comprehensive actually. I have 2 points to ask. First, I understood very clearly from you that the obesity is the hallmark of metabolic syndrome, because some people were advocating this is just a consolidation of a risk factor. Second is there are some thoughts about the mechanic. You talked about the hormonal and metabolic factors which enhance diabetes and cholesterol and blood pressure. But there are some thoughts about a mechanical factor also, which is the pressure from the adipose tissue on the renal arteries and the causation of blood pressure. What is your thoughts about this?
Yeah, the renal artery, of course, as I said earlier, there is the cardiorenal syndrome, and there is a relationship between all the vessels, as I said, perivascular adipose tissue for the heart and for the kidney are the same, and they can ultimately lead to the same problem: atherosclerosis, stenosis, renin-angiotensin system activation. And I think, to be honest with you about it will be nice to see that now we're getting back again about renal denervation. And I wonder if the renal denervation thus is not getting now again earlier we said the sympathomimetic, and the parasympathomimetic, just by the denervation, you are taking this component out. And when I was in Egypt many years ago, and I think there was some body, I believe, from the armed forces hospital, whatever, discussing some data. And I told them, have they looked of the denervation difference in obese subject versus non-obese subject? Because what we might be doing there, just taking the overactivation from the sympathomimetic and causing that. So I think that the other thing is, I remember you very well, Professor Fathi Maqlidi. I many years ago, you were the one who asked me the first question when I was talking about obesity in Egypt. I think you remember that you asked me after I finished and about the bariatric surgery and obesity and the benefit. You recall that discussion?
Yes, I do.
And I told you at that time, it was article coming right out, which I think might be appropriate to talk about it now, which showed the benefit that the bariatric surgery, before they took them to do the surgery, they did an MRI on the heart, and they saw in the MRI some abnormality and fatty infiltration. And guess what? After they had the bariatric surgery and the whole thing improved and the diabetes gone, etc., they went back and did the MRI and it was gone. And that study, I believe, I still always think about. So there is a lot to think about the epicardial fat and the perirenal fat. It would be a good, nice study if you can do it in Egypt, really. Because I have not got the population for that to see what the perirenal fat and hypertension.
Oh, I think this is a good point of research, sir.
I think so. And next time when I come to it, I would love to visit with you, Dr. Gamil and Dr. Claudia. But in Suez Canal, maybe we could do some project together because I'm sure you
Yes,
have.
we can do. Yes,
Dr.
sir.
Mahmoud, we have observed here in Egypt that the ladies with morbid obesity have severe hypertension. And this is an area which we need to do some research jointly with you. You give us some ideas. The people, or particularly women, which is not uncommon here, with morbid obesity, have severe hypertension. They come with hypertension 240 over 113 and so on, in that range. And I believe, and you correct me, of the patient, of the person come to the stage of morbid obesity, diet regimen or even drugs will not have a benefit. The benefit will come from bariatric surgery. What do you think? Yeah.
Now, of course, as I said, once we exhaust our non-surgical approach, having said that, this is the area, and I think I already published a paper already on that post-menopausal woman. So what's happening is the premenopausal, as you know, the problem with female start after the age of 59 or 60 when they get truly in the menopause. And we have published data already showing that the excess epicardial fat in female once they get in the menopause. And we associated that with significant structural and functional abnormality, including hypertension. So again, that is now. To answer your question directly about what to do about it, there have been recently some studies, unfortunately, some data that the semaglutides, I'm sure you have it in Egypt now, the semaglutide, Ozempic, not only just good for the blood sugar, but good also for weight reduction and reducing the epicardial adiposity. So reducing the epicardial adiposity. That might be another thing to consider using in this group of patients, not only just for the sugar, but also for the weight reduction, and automatically the epicardial fat also go down, and you might get a double whammy here.
Yeah, just very good point. I think the literature is talking a lot about semaglutide as an important pharmacotherapy for obesity, actually, rather than for diabetes. That's quite right. I hope in your coming visit to Egypt, we'll arrange a visit to our school in Ismailia. I don't think you have visit us in Ismailia, and in our school. I arranged with Dr. Gamila Nasser that you come to us and discuss a lot of points about this very, very important. You open a lot of a new point in this
research questions. Yes, sir. Yes, I agree with you, Professor Fathi. I think maybe we'll have the honor to invite Professor Shahawi to our school, maybe when he's in Egypt, and physically, and maybe in 1 or 2 months, and we will be very eager to arrange mutual research registries for something or that. I agree with you, sir.
It will be my honor and privilege to do so. You know how much I like both of you. You're good
Thank you.
friends for ages.
Thank you. It's our honor.
Thank you, Professor Mahfouz, for the elegant presentation. And for the sake of time, we have to move on to the second lecture. The second lecture will be about managing cardiovascular risk factors in Ramadan. It will be presented by Dr. Mohammed Miri. He is lecturer of cardiology at South Carolina University. Please proceed, Dr. Mohammed. Dr. Mohammed, unmute yourself, please. Dr. Mohammed, unmute yourself.
Assalamu alaikum, Dr. Ahmed.
Alaikum assalam wa rahmatullahi wa barakatuh.
I am very honored to be with you today, especially with my elegant professor, Dr. Fathi al-Maqladi and Dr. Jamila. And
Thank
it's
you.
my pleasure to talk about my presentation today. Is it here or not?
Yeah, we can see it, Mohammed.
You can see the presentation?
Yeah. All right.
Okay,
You can see that
I'm very pleasure to meet you this good evening, and my pleasure to speak in front of my professor, Dr. Fathi al-Maqladi and Dr. Jamila. And it's my honor to be with Dr. Mahfouz Shahawi, a big star in prevention cardiology, and with my senior and my big brother, Dr. Ahmed Farid. Today, we will talk about the effect of Ramadan fasting on cardiovascular risk factors. Is my voice okay?
Yes, okay, Mohammed, we hear you.
First of all, we do an introduction about the Ramadan and the Muslim people. The high incidence of cardiovascular disease in most Muslim population. The high incidence of cardiovascular disease in most Muslim population in the assessment of the effect of Ramadan on the cardiovascular outcome and the parameters is very important thing. Ramadan fasting has a unique properties and with intermittent fasting, like Dr. and Professor Mahfouz said, which is currently now a popular eating pattern used for losing weight. Fasting has a positive effect on insulin resistance and the cardiovascular risk metabolism. Ramadan fasting has also a positive effect on decreasing psychological and depression and anxiety. This is a health benefit, as Dr. Mahfouz said, and I don't go longer because of the time, that Ramadan show a health benefit regarding insulin sensitivity and decreasing insulin resistance in cardiometabolic profile, decreasing the heart rate and the blood pressure and the cardiac work. Again, this is how long time taking for Muslim peoples to fast. It varying from different countries. It measurement around 18 hours in some countries like London and Oslo. Again, the fasting may provide a cardiac protection even after a cardiovascular event. Several studies has observed that Muslims with a history of decompensated heart failure had a decreased incidence of acute decompensation from heart failure during Ramadan compared to the rest of the year. Most patients with a stable heart disease can fast without any problem. This is depending on geographical location in the climate and seasonal timing during fasting. Again, comorbidities and risk factors such as age, gender, health, duration of fasting and food intake before fasting may be fasting individual cardiometabolic risk. Patients with cardiovascular disease frequently have a comorbidities like diabetes and CKD, and this category of patient considered as a high risk for fasting and shouldn't fast. This condition can interact with cardiovascular disease, such as atherogenic hypoglycemia, which is more common in patients with uncontrolled diabetes, which trigger the arrhythmia in these patients and making them high risk for fasting. Therefore, it's essential to take a holistic approach when individualizing each patient with a cardiac disease undertaking Ramadan fasting. That's why our agenda today is risk stratification for people, Muslim people going to fast, management of cardiovascular risk factors in Ramadan, pre-Ramadan and Ramadan, post-Ramadan checklist, and finally, recommendations and conclusion. We will start firstly with risk stratification of patient for fasting with a cardiovascular disease. We categorized each patient for 3 groups, even a very high risk group, and this group shouldn't fast, and the patient with high risk score, and this patient should not fast, and patient with low moderate risk, which may be able to fast. Regarding the patient with moderate or low risk who can able to fast, this are the category: patient with a stable hypertension, patient with a stable angina, patient with a stable non-severe heart failure, a patient with implantable loop recorder, permanent pacemaker, patient with supraventricular and tachycardia and atrial fibrillation. And this is very important that patient with atrial fibrillation is considered as a moderate risk for fasting. And finally, patient with mild to moderate pulmonary hypertension. Otherwise, patient with high risk who shouldn't fast. This patient who poorly controlled hypertension with recent acute coronary syndrome, myocardial infarction, less than 3 weeks, and another studies said that then 3 months shouldn't fast. Patient with hypertrophic cardiomyopathy with obstruction, that meaning that their LVOT obstruction level is more than 30 millimeter mercury, severe valvular heart disease, patient with severe heart failure without evidence features, and patient with poorly controlled arrhythmia. Lastly, patient with implantable cardioverter ICD or patient with CRT. This patient considered as a high risk and shouldn't fast. But it's regarding the patient and the doctor strategy, they can manage self-stratification of this patient. Lastly, the patient with very high risk, and this patient must not fast and is contraindicated for them to fast. Patient with advanced heart failure, that their ejection fraction is less than 35%. Patient with NIA class 4 to 3. Patient with a history of hospitalization less than 6 months before Ramadan, and patient with severely impaired functional capacity, like 6 meter walking test is less than distance 300 meter alone. Again, patient with severe pulmonary hypertension, who is defined that is severe pulmonary hypertension with significant RV impairment. This patient is considered a very high risk patient and must not fast. But what about suggested pre-Ramadan and post-Ramadan checklist? This is a checklist we should do for each patient, individualized, to take his Ramadan safely without complication. Suggested pre and post-Ramadan checklist, including the following: establish the patient background, including previous Ramadan fasting experience, symptoms status, smoking status about this patient, cardiac and other medical history, and medication and compliance. And we will then review the recent investigation regarding the electrolyte imbalance and the ECG and the imaging, especially echocardiogram, to see the functional assessment and ejection fraction of this patient. Next, we should do the risk stratification, communication, and management. We should each patient risk stratify him, refer to Ramadan and diabetic and CKD. This patient shouldn't fast, when the communicable risk should be advised to the patient. Lastly, this is a general Ramadan advice that healthy diet and fluid intake, smoking break when this is a good opportunity in Ramadan, titration fast if feeling unwell, and that we should tell the patient is that IM injection and cerebral lingual injection shouldn't break them fasting. But if we spoke about cardiovascular risk factors, we including the following: hypertension, diabetes, dyslipidemia, arrhythmia, smoking, and sedentary life. We will talk shortly about each one of these risk factors and how to manage during Ramadan. First of all, we will discuss the hypertension. Many factors may theoretically influence blood pressure during Ramadan fasting. This including feeding pattern, sleep change, type of antihypertensive agent taking for this patient, and change in timing of medication. Ramadan fasting appeared to significantly decrease systolic and diastolic blood pressure, especially systolic blood pressure, and this is well tolerated without complication. Also, in the meta-analysis and the randomized trials, there is improvement in blood pressure control, even in patients with CKD, irrespective of renal function, and improvement in arterial compliance in those patients, but patients without CKD. It has been reported that ambulatory blood pressure didn't show a significant difference between fasting and the non-fasting patient, but this trial was done in winter season. But if we do it in summer season, I think that its systolic blood pressure will significantly drop than other times of the day. And this is examples of trials showing the effect of Ramadan on fasting on blood pressure, showing that systolic and diastolic blood pressure, especially systolic blood pressure, is decreasing in patients with fasting less than patient without fasting. Again, hypertension from the other side of the coin increased the number of hypertensive related visits in emergency, increasing in Ramadan. This is because of poor compliance, and this is aggravated by neuroendocrine changes happened with hunger periods. One of the famous fluids taken in Ramadan, that is licorice, which have a very significant implication on hypertension, which increasing hypernatremia and decreasing, causing hypokalemia and increased fluid volume. All of this is a very dangerous, life-threatening conditions that having to hypertensive patient, especially going for hypertensive pulmonary edema in patient with cardiovascular disease. So what to do in hypertensive patient, fast or not to fast? According to these guidelines, all patients with hypertension should be individualized to risk stratified for each physician. Blood pressure controlled patient is not hypertensive, is not contraindicated for fasting. That patient with controlled hypertension is not contraindicated, and we should prescribe the medication to take in once or twice daily. Of the patient taking his medication 3 times daily, we should advise him to take it twice, or even better to take it once, single pill. This is better for patient hypertensive in Ramadan. But who is patient is hypertensive and contraindicated to fast, that patient with uncontrolled hypertension. Diuretics is not recommended during fasting, especially because hypovolemia, and the licorice excess take in Ramadan is also contraindicated. Second risk factors is diabetes, which is a very strong risk factors in Muslim country. We estimate that more than 150 million patient Muslim have diabetes, which is a very large number in around the world. That's why there's a recommendation for management of diabetes during Ramadan, showing that risk stratification is a very important thing in diabetic patient. And the 4 items to take risk for this patient is hyperglycemia, diabetic ketoacidosis, hypoglycemia, and dehydration and thrombosis. We should take risk stratification for each individual diabetic for these risk factors. So if we classify a patient with diabetes for fasting, patient with very high risk for fasting, and this patient shouldn't fast. This patient with severe hypoglycemia during the 3 months before Ramadan. Patient with severe hyperglycemia, that's hemoglobin A1C is more than 10, and random blood sugar is more than 300 milligram per deciliter. Patient with history of recurrent hypoglycemia and hypoglycemia unawareness. Patient with diabetic ketoacidosis and hyperosmolar hyperglycemic state 3 months before Ramadan. Patient with acute illness. Patient with performing intense physical work, and all diabetic patient with intense physical work shouldn't fast. Pregnant patient, any patient diabetic and the pregnancy shouldn't fast. Patient with chronic dialysis, and the patient with significant dementia or cognitive defect. What about a high risk patient that may choose not to fast? Patient with moderate hyperglycemia, his hemoglobin A1C is more than 8%, and the random blood sugar ranging from 150 to 300 milligram per deciliter. Patient with significant microvascular or macrovascular complication from diabetes, elderly, and the patient living alone and treated with insulin and sulfonylurea. Even the type of the medication for diabetes is a risk stratification. Patient with comorbidities and elderly patient, as we said. Again, the moderate risk patient who should choose to fast with caution. Patient with type 2 diabetes with no complications. This is very important. Is their hemoglobin A1C is less than 8 and not taking insulin or sulfonylurea. Low risk diabetic patient. This is the patient with type 2 diabetes when hemoglobin A1C less than 7 and maintaining lifestyle intervention and just metformin or TZDs or incretin-based therapy as a management for diabetes, not again a sulfonylurea or insulin. And lastly, we encourage this patient to advocate hydration during Ramadan. Risk stratification of individual with diabetes before Ramadan and in Ramadan, showing that patient with risk factors and diabetes, studies show that have showing the fasting increase the risk of this event, but not as a significantly statistically important. And this is recommendation according to the medication and the type of insulin and how to use it and how to modify the dose. Third thing is dyslipidemia. The effect of Ramadan on fasting on lipid profile, like Dr. Mahfouz said, my professor Mahfouz said that they have a significant change in lipid profile of patient with a cardiovascular disease during fasting, that decreasing total cholesterol, decreasing triglyceride, increasing HDL, and decreasing LDL, and lastly decreasing the body weight, but not affect the whole body circumference. One of the most important things happened for fasting that's called postprandial hypertriglyceridemia, which is correlated with coronary artery disease and the ischemic burden for the patient with cardiovascular disease. Each time increasing the postprandial hypertriglyceridemia, the incidence of cardiovascular disease, mortality, and morbidity increase. Ramadan fasting showing that incidence of postprandial hyperglycemia is decreased, and this is a very protective event happened during Ramadan, decreasing atherosclerosis and the incidence of coronary artery disease during Ramadan. Also, postprandial hypertriglyceridemia, which decreasing in Ramadan, decrease the insulin resistant and increasing the insulin sensitivity in diabetic patient, and this is a very big benefit of the Ramadan in diabetic patient. Number 4 is arrhythmia. Disturbed cellular metabolism and ion channel function can result in significant arrhythmia during Ramadan. Carman and Dugan report a symptomatic high burden of BVCs noted in patient during fasting. The ECC 2020 showing that a patient with sport cardiology recommendation that good hydration is a very important thing, especially with a patient having long QT syndrome, and this patient is not contraindicated to fast. Again, American Heart Association guidelines state that sleep cycle and psychological disturbance in fasting during this patient may induce atrial fibrillation. And if we consider the recommendation, all patients with ventricular arrhythmia should be evaluated by his physician. And fasting may be tolerated in most patients with atrial fibrillation. This is a very important thing, that atrial fibrillation is not a contraindication for fasting. All patients with intracardiac device may be evaluated for fasting, but patient with ICD or CRTD is contraindicated. Patient with HOCM, hypertrophic obstructive cardiomyopathy, and there is a very high risk of dehydration, so this patient is contraindicated to fast. The patient also with Brugada syndrome and long QT syndrome is contraindicated to fast, and fasting should be avoided in patients with uncontrolled ventricular arrhythmia. So if we talk about atrial fibrillation, we have a very significant number in patients with diabetes or patient with cardiovascular disease. We will find that 70% of patients receiving warfarin and 30% remaining taking direct oral anticoagulation, 50% of them modified their anticoagulation dose during Ramadan, either due to intake in time or skip doses, or that patient taking twice daily medication can't do it in Ramadan. So there is a big problem in patient with anticoagulation during Ramadan, especially patient with atrial fibrillation, making them more risk for bleeding or even stroke. That's why we recommend that patient with atrial fibrillation, non-valvular atrial fibrillation, should take once daily direct oral anticoagulation, better than warfarin and better than twice daily taking direct oral anticoagulation. Fifth, smoking. We all know that when we smoke, there is a big benefit, and we can take Ramadan a very good opportunity to quit smoking and start smoking cessation, because we are fast from smoking more than 15 hours per day, and this is a good opportunity to stop smoking. Lastly, sedentary life. Ramadan is not a big issue to stop sports. We recommend sport during Ramadan, because body weight loss and the mood change in athletic is disturbed during Ramadan if they stop athletic exercise. And this is our recommendation for exercise during fasting, that exercise is not a contraindication for fasting. If we do exercise, it's recommended after sunset and before sunrise. Competitive physical activities such as football and volleyball should be organized after sunset. A training load and food and fluid intake should be in athlete monitored and well organized with a special diet physician and his special cardiovascular doctor. And performing intense training session, it's not also contraindicated, but it's preferable to do it in early evening before suhoor. Lastly, our recommendation and conclusion that all patients with type 2 diabetes should be warned of strict adherence, medication, and healthy diet during fasting. All patients with coronary artery disease willing to fast should be individualized to risk stratified, as we mentioned before. Fasting may be tailored in most patients with stable coronary artery disease, but fasting should be avoided in patients with CKD and the patient with coronary artery disease. It should be avoided in patients with recent primary continuous intervention PCI within 3 months, and should be avoided in patients with recent acute coronary syndrome less than 3 months before Ramadan. Patient with valvular heart disease or patient with pulmonary hypertension, according to the risk stratification, we will do patient with mild to moderate valvular heart disease or moderate pulmonary hypertension can fast, but patient with significant valvular heart disease or severe pulmonary hypertension should avoid fasting. Based on, as I mentioned, data we discussed before, patient should classify to low or moderate or high or very high risk. Patient with high risk or very high risk shouldn't fast. Pre-Ramadan clinical assessment is a mandatory. This should focus on the assessment of multiple factors, including age, variability, functional capacity, symptoms, lifestyle, modification, and other concomitant disease such as diabetes and CKD. The potential risk benefit of fasting should be discussed, with final decision to fast or not to fast is clarified individually with each patient and each doctor. It's also important to follow up low risk patient, not because of they are low risk that we don't follow up them during Ramadan. And last, and my final conclusion, that physician may recommend a break in any time to save the life of the patient. Thank you and happy Ramadan for all.
شكرا دكتور محمد for
Thank you
this
very
elegant
much.
presentation. وصراحة presentation is very important for
محاضرة
all of us
ممتازة.
to learn it before even starting Ramadan, to know who should fast and who should not fast, and how to modify your patient treatment before the fasting. Thank you, Dr. Muhammad, for this elegant presentation. For the sake of time, we have to move on to the last speaker, Dr. Omar Saleh, lecturer of cardiology at South Carolina University.
Dr. Ahmed, can we have a couple of minutes to ask Muhammad a few questions?
Okay, تفضل دكتور فتحي.
شكرا يا أحمد. والله فعلا Dr. Farid said it's very important lecture in this time of the year Ramadan, because there are many questions. First of all, you put a lot of recommendations. These recommendations are based on consensus level evidence C or on research. النقطة الأولانية. النقطة الثانية يعني أنت في بعض الحاجات يعني أنت بتقول مثلا العيان بتاع اللي جاله acute decompensated heart failure should wait 6 months before he can fast. I believe this is too long period. Acute decompensated heart failure, once he stabilized, 6 months is too long period. He can fast after 1 month or so. Number 3, the question of insulin-dependent diabetic. There was a strong belief that the patient on insulin should not fast because of the fear of the hypoglycemic reaction. What is your comment on these 3 points?
Thanks you, Dr. Fathi. About the first point, that the patient with decompensated heart failure can't fast for at least 6 months. First of all, patient with risk decompensated heart failure.
What is the evidence? Is any study done about this?
This is an observational study, not a randomized trial. Yani this is an observational study, not a big randomized trial, but we can take that the risk stratification of patient with decompensated heart failure is different. Patient with hospitalization during the last 3 months, or patient not optimum on medical treatment, on patient showing advanced heart failure manifestation symptoms or signs.
Yeah, you're right. يعني the patient with acute decompensated heart failure can be stabilized within a couple of weeks.
Of course, if they stabilized 3 weeks before Ramadan, they can fast. This is first thing. Second item, that recommendation is from Turkish and from British studies, but not again a generalized or guidelines that to be on all countries. But this is a recommendation just from Turkish and British studies, not a generalized guidelines to take for this. Second thing, that the patient with diabetes and insulin therapy, insulin therapy is different, even so pre-mixed or just a long-acting insulin therapy. That different from patient to patient. Patient with pre-mixed insulin, we should modify their dose according the doctor with follow-up, and a patient with just taking 1 dose of insulin, long-acting insulin, they can fast safely. But patient with insulin and sulfonylurea, or patient with pre-mixed insulin and uncontrolled, and their pre-Ramadan fasting random blood sugar is more than 300 milligram per deciliter, is considered as a high risk and it shouldn't fast.
Thank you.
طب دكتور محمد، انا ليا بس question. اليوز بتاع الدايريتكس بالنسبه للعيانين الهارت فيلير during رمضان، في اي ريكومنديشن او في اي كونسنسس هاو تو يوز ات، التايم تو يوز ات؟ هل محتاجين نقلل الدوز بتاعه الدايريتكس؟
مشكله رمضان في حاجتين. الحاجه الاولانيه التايمينج اوف ذا رمضان. Is it in winter season or in summer season? Because the dehydration and the hypovolemia is a very important thing, and the risk factors happened in a cardiovascular patient. بالنسبه للدايوريتكس two things can do. يعني either inhibit الدايوريتكس just to be avoided if the patient is stable and in summer climate, and or to increase the dose, to modify it to half the dose during Ramadan. And especially a patient taking diuretics, we should monitor the serum creatinine and the urine analysis and the albumin creatinine ratio in this patient. If a hypertensive patient taking diuretics before Ramadan, we should follow up this patient from the serum creatinine and the urine albumin creatinine ratio in the urine analysis, because diuretics in this patient is less dangerous, and we should modify the dose to be half the dose from taking before Ramadan.
طيب هل التايمنج بتاعه يعني it's taken in the early in the morning او مثلا يعني قصدي انها تتاخد بعد الفطار على طول، او هل انها تتاخد مع السحور مثلا؟ هل this make any difference؟
بصراحه ما فيش observational study او randomized trial اتعملت على الاسسمنت بتاع التايمينج للدايوريتكس، but it's better to take before افطار because it's more safer for the patient to take it, because if they take it before suhoor and the hypotension or postural hypotension happened, this is also a risk for the patient during Ramadan. So if we will recommend that before iftar. And I wanted to know what about your opinion or experience.
I agree with this concept, and this is my practice actually. Diuretics are quite important in a patient with heart failure, but he can tolerate it if you give it before breakfast immediately, as we do before breakfast in non-Ramadan, and you have 10 hours that the patient can diurese during this hours without any effect on the cardiovascular system.
Yes, sir. Yes.
Thank you, Dr. Muhammad, for the presentation. Moving on to the last lecture by Dr. Omar Saleh, lecturer of cardiology of South University, and he will talk to us about the PCI in Ramadan and what you need to know. تفضل دكتور عمر.
بسم الله الرحمن الرحيم. Thank you very much, my dear friend, Dr. Ahmed. I am very glad to be here with you, Professor Dr. Jamila, Professor Dr. Fathi Maqlidi, and of course our guest, Professor Dr. Mahfouz.
Thank you.
The topic that Dr. Ahmed asked me to talk about is not that long, actually. It's very brief notes we'll go on. And I'll ask Dr. Mary, please, can you unshare your screen, please?
Stop sharing the screen, Dr. Muhammad. Okay.
شكرا Dr. Muhammad. Is it clear now?
Yeah, we can see it here.
Okay. So actually what I'm going to talk about already have been discussed during Professor Shahawi and Dr. Mary lectures. There is no data, as you all know, that there is no available data and no randomized trials that's available for us to talk about. And actually all the points that Dr. Mary talked and mentioned in his lecture is from consensus from many societies in the Muslim world and also in the UK or in the Western countries. There's approximately around 1.8 billion Muslims in the world, and only 93% of them are likely to observe Ramadan fasting. And this is important for us because of the increasing prevalence of the cardiovascular disease in our communities, and also from patients asking for their suitability for Ramadan fasting. In our clinic, every day you have the patient that asks you, should I fast or not? And you face this to 2 points. First of all, the faith. The patient has a strong faith that he should not, he should fast Ramadan. He should not lose the chance of fasting Ramadan. And the second point is the disease, the illness. Is the patient suitable for this or not? So your word is very important for the patient. And if you convey the message in a suitable way, the patient will accept either to fast or not to fast during Ramadan. And as everybody knows that stopping eating and drinking in Ramadan for a period of time is very important for the medications the patient takes and for the fluid level in his body, and also not only the eating or drinking, but also the exercise, the sleep pattern, and smoking habits in some people. This is very important considerations in Ramadan. As Professor Shahawi mentioned, the effects of fasting on cardiovascular system is positive, and this due to the psychological stress and depression and anxiety that's decreased in Ramadan, and also the decrease in the heart rate and respiratory rate and the blood pressure, as Dr. Mary mentioned for us. Both the systolic and diastolic blood pressure reduced during the fasting, explained by the decrease in sympathetic tone, counterbalanced by an increase in the parasympathetic tone. Not only this, but the pro-inflammatory markers also decrease. The homocysteine, the interleukin-6, and C-reactive proteins, these reduce. And this is very important in the admissions and also in the occurrence and the incidence of myocardial infarction or ischemic heart disease or heart failure in patients during fasting Ramadan. The higher vagal activity has been associated with decreased level of inflammatory cytokines, and it's well known that the nitric oxide levels in patients fasting Ramadan is better than those in non-Ramadan times, and this is very important for the endothelial function in this group of patients. It appears also that fasting and intermittent fasting decrease the levels of the lipids, the HDL, the LDL, and triglycerides, and the very low density lipoprotein, resulting in a decrease in patients for developing cardiovascular disease, decrease during fasting. And this provides sufficient cardiac protection even after the patient has an event. This gives him more and more protection. In some of the studies that has been done, small-scale studies have been done in some of the Muslim countries, with the history of ischemic cardiomyopathy, they have decreased incidence of acute compensated heart failure during Ramadan compared to the rest of the year. And this is very important. So if you go through the main topic, the PCI and fasting in Ramadan, we have three entities: the before the procedure, during the procedure, and what about after the procedure management for the patient. Let's start with the before the procedure. As Dr. Mary said, as you can see here in the moderate to low risk is the patient with the stable iron. Here the patient can fast or may be able to fast Ramadan. And otherwise, in the high risk category that should not fast is a patient with a recent acute coronary syndrome or myocardial infarction. And likely that the very high risk patient, we don't have only two group of patients: patient with advanced heart failure and the patient with severe pulmonary hypertension. So from this, the patient with stable heart disease can fast. Although there is no definite consensus, it seems safer for a stable patient who have done already or are followed up with proper medical treatment after acute coronary syndrome to fast after completing the first 3 months following the index event. So if the patient has an acute coronary syndrome, but after acute coronary syndrome event, this index event, there's 3 months, that's better not to fast during these 3 months. But you can tailor this to the patient. If the patient is stable, no symptoms, he is controlled the medications, very low number of medication that he is taking already during the day, he may fast relatively. Individual evaluation of patient with coronary artery disease is essential, and this period can be extended based on individual risk assessment, and that's what I've been talking about. You have to individualize the guidelines, and you have to take every point, not to tailor every point for your patient, and not to take one model only. During the preparation of the patient, actually, you have to follow the same procedure as non-Ramadan days. Fasting before the procedure for a long time is not recommended, and as you know this because of the contrast we have given the patient, and also due to the hazard on kidney function. And during the hospital stay, you should follow the regular preparation process as per protocol, as if the patient is not in Ramadan. You should ask the patient not to fast during this procedure. After the procedure is very important. Fasting within the first 3 months can be dangerous in newly revascularized patient following an acute coronary syndrome. This due to the high risk of thrombosis in this patient, and also in patients with high syntax score after a complex PCI procedure. This may be due to the dehydration and tendency to stent thrombosis, especially in summertime fasting. After 3 months, you can tell your patient to fast safely. And although low-risk patients with a normal systolic function who underwent PCI may safely fast Ramadan, but however, general consensus from some societies prefer the 3 months period after PCI for those patients. And regarding the medications, the drug intake is affected by fasting, as you all know, and it depends mainly on the product characteristics. Each drug has specific pharmacodynamics and pharmacokinetics, which affect its steady-state plasma levels within therapeutic range. So the change in time intervals between doses may result in fluctuations in the plasma levels, particularly for drugs that are given in multiple doses. As you have to put in mind when you are prescribing your medications for the patient during fasting Ramadan. Some studies have revealed that majority of the patients change the intake pattern of their drugs during Ramadan. The patients from themselves, they change the pattern of the drugs they are giving already in Ramadan. And we'll go for individual drugs, as you have discussed before, the diuretics. And you know that all this is about the consensus, about the practice from different physicians. And the diuretics can augment dehydration during fasting, which may increase adverse drug reaction and may cause acute kidney function. And as Dr. Mary and our professor, Dr. Fathi, told us that we have to reduce the dose in heart failure patient, and also you have to see the patient or contact the patient every now and then to determine his status now, his symptomatic status now, and tailor the diuretics on this symptomatic status. And you have to know that you can give the patient every other day. You can give the patient smaller dose and so on, but monitor the kidney function and electrolyte levels when you are doing so. Some of the studies recommended these diuretics to be given at suhoor, not at iftar. Although in my practice, I give it before iftar, like Professor Fathi Makledi told us. because the rationale that if you give the patient an iftar, this may affect the sleeping pattern of the patient, and he cannot go to sleep due to necturia. But regarding the ACE inhibitors, the ARBs, they can augment dehydration during fasting, may have action also, such as orthostatic hypotension, electrolyte imbalance, and acute kidney injury. You have to monitor the kidney function and electrolytes, and you can give these medications after iftar. Taking medicines immediately after large meals, these medications, if given after large meals, may cause hypotension and orthostatic symptoms, and take care about this. Regarding the beta blockers, also dehydration during fasting may increase its adverse drug reactions. And you can give these medications after iftar, and taking medicine immediately also after meals may cause orthostatic hypotension, and you can spread the daily dose if you can do so by the medication. And also this regarding the calcium channel blockers, it have the same problem. It can cause increased adverse drug reactions, and also may cause dizzy spells if given after iftar. Regarding the antiplatelets, actually the only one that is you have to consider if giving antiplatelet to the patient is the ticagrelor, because ticagrelor should be taken twice daily, and its plasma half-life is sorry, it's around 7 hours. Sorry. Short plasma half-life, the ticagrelor, the patient may have some time without drug activity in the plasma. So if it's okay, you can shift the patient to a single daily or once daily antiplatelet agent, and of course you have to bridge this with loading doses, as you all know. Regarding the long-acting nitrates, it can be taken in suhoor and then late in iftar. There may be a loss of pharmacodynamic effects in patient if they are taking ticagrelor with them. Consider advising the bedtime dose. Avoid taking immediately after large meals due to risk of significantly decreasing the blood pressure of the patient. What about during the procedure? And I'll have to stop here. And which one should we consider during the procedure? You know that the patient, you have already prepared your patient. You are dealing with the patient as if he is not fasting in Ramadan. So during the procedure, which one should we care about? The operator or the patient? I am an intervention cardiologist, and I'm asking you, who should you care for? The operator or the patient? Already your patient served it well, and you have prepared your patient well. But I'd like you to think about the operator here. This is because the radiation exposure already is a recognized risk factor in personal staff performing fluoroscopy-guided cardiovascular procedure. And the dehydration also increases the risk of radiation hazard for personnel in the cath lab. Also, if you are standing in a long tiring procedures, impose a greater risk on the operator during fasting. This is adding to the work stress. You are we're working in a stressful situations, you sympathetic overstimulation during this procedure. So it's preferred to minimize the radiation exposure and ensure safety during the procedure, and also to, I don't know, we cannot minimize work actually, but we have to maybe working in a very simple procedure more than the complex procedure during fasting. And you can postpone the patients, the elective patients, postpone after iftar. Maybe there is no recommendation regarding this. So my take-home message that there is an increasing body of evidence suggesting that fasting improves cardiometabolic risk factors for the primary prevention of cardiovascular disease. Stable patients undergoing simple procedure can consider fasting. Complex procedure and the patient who have done complex procedure following primary PCI, fasting is not recommended. However, it's preferred not to fast during the first 3 months for all groups, and operators should watch for increased occupational hazard during fasting. And thank you very much.
Thank you, Dr. Omar, for the elegant and concise presentation. Stuck to the time, يعني.
Very nice presentation.
Very elegant. حابب any comments يا فندم؟
ايوه نعم. انا I need to take a couple of minutes كده between us to discuss the timing of the fasting after acute coronary syndrome. محمد المري وعمر صالح قالوا 3 شهور. I believe it is too long period. ليه بقى؟ لأنه دلوقتي مع النوشن of the upgrading of the primary PCI، العيان بيجي له acute coronary syndrome بتعمل له primary PCI، وبالتالي ما بيحصلش فيه salvage للميوكارديوم if you revascularize the patient early. And if the patient is stable means what? Stable, he has no chest pain, he stable coronary syndrome يعني كويس والامور كويسه. Also if the myocardium function is okay يعني means in the ejection fraction before above 50 or above 45%. Why not the patient can fast after in my opinion 2 weeks. نحب نسمع راي الدكتوره جميله في القصه دي وراي احمد
والله
فريد
فندم
برضه. ها
I agree مع حضرتك.
ضيع معانا اهو، ده ضيع معانا كمان، نسمع الراي ضيع.
دكتور ضياء معانا
السلام
وانا
عليكم.
مبسوطه قوي الحقيقه انك
دكتور
انت معانا.
فتحي، دكتورة جميلة،
اهلا
دكتور
دكتور
محفوظ, my
ضياء،
dear
رايك؟
colleagues, my pleasure.
Thank you.
I
We are happy
completely,
to have you with us.
it's my pleasure to be here with you from the beginning, and I'm learning a lot. Completely agree with Dr. Makladi. We have to do risk assessment for the patients after PCI, and if the patient can fast, we shouldn't wait for a long time. Especially we have the guidelines now that we can do risk stratification after PCI, even after cabbage, and then like if the patients can fast, we shouldn't wait for a long time according to the risk stratification. Completely agree. 3 months is too long. Like that can be
Yes,
a couple
I think
of
so,
weeks
sir.
or 3 weeks.
I think this is too much because there are no real, studies, and I think all these are just based on consensus. So I think it's too much, and I think it's time for us to have real studies in Egypt for that. And I think we need to Egyptianize the guidelines. I think so.
Exactly. If you allow me, I'll just like take a couple of minutes to comment on something earlier of like a point of Dr. Mahfouz's lecture, and Dr. Makladi also like mentioned the point of perivascular fat and perirenal fat. It's a very important point, and it might be a point of interest of research even in Egypt, like to do some ethnic differences between the Egyptian and like the other patients. Returning back to the point of Dr. Makladi about the perirenal fat, and I think Dr. Mahfouz knows about the renal denervation that showed that we were working in a study, the spiral study causing renal denervation, and they showed the reduction of the blood pressure, but without like just a limited reduction of blood pressure, but the effect of perivascular perirenal fat can be a very good point of research. Actually, we're still working on it, and like it's using the CAT scan to assess the perivascular fat as a risk factor, and using the denervation technique using the such a spiral trial. This is one of the most important points. We would love to work on research, especially on we don't have any data in the on the Egyptian patients.
Yeah,
Yes, I agree with you.
You're quite right. Actually, the problem of obesity is growing in Egypt. And as I just mentioned, I have noticed personally that the patient with morbid obesity, they come with severe hypertension, severe alarming blood pressure. And I think this is a point to which we need to do some research about this. لأن يعني أنا دلوقتي I record them. I have a list in my clinic على العيانين دول. الناس بتيجي blood pressure يعني very alarming, 240 over 130 and that sort of figure, which is very alarming.
And the point you raised, Dr. Makladi, the point of perirenal fat
yes.
as a mechanical factor, it does make a lot of sense, because even in the renal denervation studies, after they did the denervation, still some patients, even the obese patients, still having high blood pressure after we cut the sympathetic innervation for the renal arteries.
Thank you.
Also, I think the matter of interest is the perivascular fat. I think it has, this is very important point because it has direct relation to the vessels.
Exactly.
So this is very making it as a source, like a factory pouring some, atherogenic factors. I think this may be of an interest to us. It's very important.
It's a big time risk factors, and we see this is one of the point we assess in CAT scan. If we see the perivascular fat in CAT scan, this is a very high risk factor for cardiovascular MACE. So that can be a very good point of research. Hopefully, we can address in Egypt.
We are arranging in the Egyptian Hypertension Society conference in May a roundtable discussion about the renal denervation. And we are inviting somebody to come from as a guest speaker or sharing. This roundtable discussion will be moderated by Dr. Arabi, and there are few centers now in Egypt is growing this activity in Egypt now.
Right, and there are people. I can share some of the colleagues here. They were working on the denervation trials, and they will be happy to share their opinions regarding this roundtable discussion.
That will be a pleasure.
It will be great. It will be great, Dr. Day.
My pleasure. My pleasure.
I think we have reached the end of this meeting, this very interesting meeting. First of all, I would like to thank Professor Mahfouz for his participation and his valuable addition to this meeting. Thank you very much for your time and for your addition. Special thanks for the speakers.
I think before we end, we have to thank you.
Thank you. Yes. Thank you, Dr. Ahmed.
This very rich meeting today.
Yes, it's very rich.
And it's really very rich. Professor Mahfouz has said a lot of new information and knowledge about the obesity and metabolic syndrome, and also Al-Marri has covered a very important subject in Ramadan, and Omar Saleh, and we'd like to thank you. And before Ahmed, we used to do this sort of meeting every month. Now, what happened?
We are back, inshallah, Dr. Fatih. Inshallah, we are planning to do it on a regular basis, inshallah.
Thank you very much. Thank you, Dr. Camila, for.
Thank you very much, Dr. Fatih.
Thank you very much. Thank you.
كل سنة حضرتك
طيبين. Happy Ramadan. كل سنة حضرتكم طيبين.
Thank you. Thank you.
Thank you very much. Enjoyed being with you. And happy Ramadan, and enjoy the iftar.
Thank you. Thank you.
Thank you, Professor Shahawi, for your endless encouragement and help. Thank you very much.
Thank you for the invite.
Bye bye.
Thank you, sir. Thank you. Bye bye. Bye bye. Bye bye.
Bye. Thank you.
Bye bye, sir. Bye bye.